already muted themselves, so thank you for that. We'll be monitoring if there's any background noise. Go ahead and unmute yourself if you have any questions. That'll be the best way to ask our presenters. If you don't want to unmute yourself, you're welcome to just ask the questions in the chat box. I'll be monitoring that as well. Please bear in mind, we'll be doing a little bit of technology changing over here. So just allow us to do that, and hopefully everything goes smoothly. Each of our presenters will be sharing their own screens so they can make note of different charts and things available. So just a forewarning there in case anything goes wrong. If you need CME credit, I'll be sending a follow-up email with that QR code. Go ahead and scan that for your CME credit. Or log into the MyCME portal to claim that credit. If you have any trouble with that, feel free to send me a direct email and I can do it on the back end for you. So just let me know and I'm happy to do that. Event evaluation is really important to us. I'll be sending that in the post-event email as well. And I'll also, in just a few minutes, plop it in that chat box in case you want to access it while the event is going on. If you want to tweet about this, we always encourage that. Our Twitter handle is up in the right-hand corner. So without further ado, I will kick it off to Navid, who will start with our clinical history. Okay, go ahead, Navid.
Okay, that was our first clinical or technological glitch. I'm hoping that we can see that, and I'm unmuted. Welcome everyone to our Clinical Pathological Correlation Conference. We'll go ahead and get started with the clinical part of things, and then we'll go back and forth between the neuropsychological and the neuropathological. So this case was a 53-year-old right-handed woman with language difficulties who presented at the age of 53, which was about 2010, to our clinic, to our neurocognitive clinic. At that time, she had already been seen by other neurologists, and she was referred to the clinic for evaluation of possible primary progressive aphasia. The history of her illness, we can actually start from her childhood and sort of background. She graduated from high school. A note was made in the chart that she was a very good speller in grade school. She completed some college and worked in a customer service capacity. There was no mention of exactly what kind of job she had done, but it was some form of customer service. In about 2007, which is 3 years prior to seeing her in the clinic, she lost her job. There was some question whether she was actually fired from her job because she was having difficulty doing more than one thing at a time. And in 2008, so about a year later, she began to have difficulty finding her words. This progressed to sort of difficulty with learning new information, and there was some issue also with comprehension of language. She was having difficulty with spelling and written output, even though in the past, as we mentioned, she was a very good speller. She could still drive in familiar routes, but having mentioned that, it sounds like maybe the unfamiliar one she was having some difficulty with. She was able to do some of the housework, and she still enjoyed doing scrapbooking. She did appear to be more subdued to her family. Occasionally she would get tearful, and other times she would laugh somewhat easily. In 2008-2009, she had the evaluation by a neurologist for cognitive decline. Her workup included MRI of brain, which was reportedly normal. She also had apparently an FTG PET. We don't have the results from that, but there were some vague references to possible left parietotemporal hypometabolism and bilateral temporal lobe hypometabolism. The report we have was also misspelled, so there was sometimes hypermetabolism. We don't know exactly which one it was, but something to suggest that. at that point, by that neurologist, she was given the diagnosis of primary progressive aphasia. She was then evaluated in 2010 at the U of M Neurology Clinic. Other histories included a low-grade thyroid cancer, which had been resected, and she was just on levothyroxine. Social history, other than sort of the educational or work background we already talked about, there was no tobacco, alcohol, or illicit drug use. Family history, her mother had dementia at age of 70 and died at age of 80. There isn't much more information about what kind of dementia or how the diagnosis was arrived at. Her father had lung cancer and alcohol abuse, no neurological diseases in her siblings, and she had 2 healthy sons. This is the physical examination at that time, at least the neurological examination. I will mention that the MMSE was 12 out of 30. In the Addenbrooke test, these are the scores that she had. Her total score was 27 out of 100. And before we go much further in the testing here, it should be mentioned that it was noted that language was a major problem in administrating some of these tests and her responses. So everything should be taken with somewhat of a grain of salt. But her attention and orientation was low, her memory was low, verbal fluency was low, language was low, visual spatial tasks were low. Perhaps worse in the measures of verbal fluency and memory and language as compared to the others. Her GDS was 4, so there wasn't really a major component of a mood associated with this. With regards to her language, these are the descriptions that we had. She had significantly reduced speech output, so it wasn't thought that she was very fluent. She had circumlocution and paraphasic errors, where she would talk around the words and describe, rather than specifics, more general terms, which made the speech somewhat difficult to comprehend. There was significant problem with repetition. Again, this is the only description that's available. And she had mild difficulty with comprehension, perhaps more complex phrases she had difficulty with. She did not have any other neurological abnormalities on the exam, no cranial nerve abnormalities, and no Parkinsonian features. So in summary, the clinical summary was a woman with a young onset, age of 50, we suspect, of gradual, progressive, primarily a language dysfunction, which was the most striking features, and in particular involving fluency. There were, however, some additional features by the time we had seen the patient, including executive function problems, difficulty with some visual spatial tasks, and difficulty with her memory, at least according to the exam. So at the time, there was, we thought that this was consistent with diagnosis of a primary progressive aphasia, perhaps moving beyond the primary part of it. And there was some concern for a non-fluent variant with an etiology that's often associated with a tauopathy related to FTDs. So that was the clinical summary at that point. So at this point, I'll transition to the neuropsych results, unless if there are any questions about the case or any details of it. So I assume no questions at this point.
So I can take over from here. So we are doing this slightly differently than we've done other CPCs, in that we are presenting the data sort of in the order that we received them chronologically. So I'm going to be talking a little bit about the neuropsychological data that we have for this patient, which is somewhat limited. Okay. So unlike previous CPCs that you might have attended where we had multiple clinical and research evaluations, in this case, we actually only had 2 evaluations for the patient. One in 2010, so shortly after her visit with the COG clinic. And there we do have some neuropsychological data, but unfortunately, we don't have behavioral observations, some of the additional clinical history that we might gather at a clinical visit. There was a second evaluation done a year later as part of the MADRC. However, as you'll see, those data are very limited. So we're going to focus just on this first evaluation to start. So as Navid mentioned, at the time she came to us, she was 53 years old and reported 12 years of education. So though she had completed some college courses, had not completed a full year. At the time, so I'm pulling a lot of these data from some of the forms that we utilize at the MADRC, so unfortunately I don't have a ton more background information, but we know that at the time that she came to us at MADRC, she stated that the predominant symptom that was most worrying to her was memory. And that's not necessarily uncommon, I think, for all patients. Sometimes patients will subjectively report memory difficulties, but will also describe other kinds of cognitive difficulties as memory difficulties. During this 2010 evaluation, her CDR score was a 1, so she was just noted to have slight difficulties with memory, orientation, and word finding at that time. So I think that's pretty notable in comparison to what was seen in the neurology COG clinic evaluation. She denied a history of mood or other psychiatric issues. At the time that she saw us, her GDS score was a 1. As Navid mentioned, there were no major abnormalities on the neurologic exam, including no motor difficulties. And in terms of the FAQ, so the FAQ is an assessment of basic and instrumental activities of daily living, and it asks the patient's co-participant or the participant's co-participant to rate them in terms of how much help they need on different tasks. And there are a variety of different cutoffs here. The score of 8 would technically fall below the cutoff, but despite that, her husband did note that she was completely dependent for financial management, so unable to balance a checkbook or write checks or complete bill pay. She needed assistance with shopping, errands, and meal preparation, and had difficulty tracking current events, although she was using things like a calendar and other tools. And it was noted that at least for the shopping errands and other sorts of daily household tasks, part of these difficulties were in fact due to her language, her communication difficulties. She really had to be accompanied out in public because some of the difficulties she was having communicating. So we're going to move to talk about the data. If you've been to CPC before, you have seen this curve. So this is just the normal curve. Most individuals on the tests that we give will attain scores that are within 1 standard deviation. And so anything that is above -1 standard deviation or up is considered normal or kind of healthy expected performance. Whereas here, anything that is falling below a standard -1 standard deviation or 1 standard deviation below the mean would be considered impaired. So this is just to give you a little bit of a grounding for the data I'm going to represent now. So again, this is this first evaluation in 2010. She did get a range of different tests. Some of the tests she couldn't complete, and I'll note those ones. And if you do have specific questions about scores, I will talk about each of the tests, but not in great detail. Certainly feel free to jump in and ask for specific scores if you'd like this. So to start with, in terms of global cognitive functioning, so she was administered an MMSE. So if you remember, her MMSE, I think, was 12 in COG clinic. It was a 15 with us. So still well below expectation, well below what we would expect and suggesting some level of impairment. She did a test of reading, which is sort of a crystallized measure. So we expect that that would generally, for most people, be a good representation of premorbid IQ. I have an asterisk here because, of course, with her difficulties, both kind of pronouncing phonemes and being able to kind of produce speech in general, we know that this is probably not the best representation. So in her case, her score was a standard score of 77, or about a standard deviation and a half below the mean. Given that she, graduated high school, completed some college, and seemingly was doing well at her job up until this point, it's probably more likely that she was in the average range for premorbid IQ. but this does speak to kind of the global nature or the severity of some of her impairments at this time. In terms of attention and working memory, she completed the digit span task, so digit span forward and backward, and there achieved scores that were between 1 and 2 standard deviations below the mean. In terms of processing speed, she completed Trails Making Task Part A, and so here she did quite poorly. So she performed at about a negative 2.33 Z-score. So in this case, what someone's asked to do is sequence numbers as quickly as they can. In her case, she, you know, had great difficulty doing this, and although she didn't make errors, she was very slow. In terms of executive functioning, she was, because she did Trails A, she also completed Trails B, but unfortunately was unable to get past the sample, so was not actually administered Trails B. So for those of you not in neuropsychology, we do have kind of sample tasks or basic versions of the task that people will, the patients will do prior to engaging in the full task to kind of teach them the rules. And in many cases, if they're unable to understand the directions or really get past the directions and makes a significant number of errors, we won't administer the full test. And that was the case here. So she was actually unable to do Trails B, so we don't have those scores. However, she was administered the 64 card version of the Wisconsin card sorting task. And so this is kind of a test of hypothesis testing and conceptualization, as well as some aspects of mental flexibility, and taps into kind of impulsivity and perseveration. In this case, her scores were extremely poor. While she did get one category, she was very perseverative and unable to shift almost at all to any other categories. And so all of her scores fell almost at the baseline. So she was scoring between 2 and 3 standard deviations below the mean here. And this in some ways does fit with this idea that she is having some difficulties with kind of organization, shifting back and forth, being able to do multiple things at once and hold different ideas in mind. In terms of her visuospatial abilities, so she did complete the Wechsler Memory Scale 3 visual reproduction test in the copy version of that. And interestingly, on that test, again, she scored about 2 standard deviations below the mean. She did also do the Benton Visual Form Discrimination, which looks at visual discrimination abilities. And on that test, she was just below the cutoff. So you have to score about 23 out of 32, and that's what she achieved. So clearly some difficulties with visuospatial functioning, maybe relatively more preserved than some of her other abilities, but not something to write home about, unfortunately. As expected and consistent with her self-report and some of the testing that we saw previously in clinic, her performance on language measures were particularly impaired. So she actually achieved on the Boston naming test is a confrontation naming task where we show individuals pictures of objects and ask them to name them. In her case, even with significant cueing, she was not able to do very well. She was only able to identify 13 out of the 60 possible, or sorry, 11 out of the 60 possible, which puts her in the very severely impaired range. She was also given several different phonemic and categorical fluency tasks, and again, performed in the severely impaired range. So when she's asked to generate lists of words that begin with certain letters or fall in certain categories, she's really having great difficulty doing that. It would have been great to have some behavioral observations to understand if that was just kind of a motor difficulty or a pronunciation, phonemic difficulty, as opposed to lots of errors. But at least we do know that she's essentially performing, you know, as low as you can on many of these language tasks. In terms of her verbal learning and memory and recognition, so as I mentioned, she did complete the Wechsler Memory Scale version 3. She did both the logical memory 1 and 2, as well as, which is a verbal memory task, as well as visual reproduction. And in terms of her verbal memory, she had great difficulty kind of understanding the task and you know, learning the information, the stories that were presented to her initially, and recalled no details, even with cueing after a short delay. Her recognition was actually not much better. She recognized fewer than 50% of the items or the details of the story. A fairly similar story for visuospatial learning and memory. So again, she has great difficulty learning the information, does not recall it after a delay, and then remembered about 50% of the images that she was shown and could recognize them and pick them out of an array after a short delay. And then finally, in terms of motor functioning, her non-dominant, so left hand speed, she performed a finger tapping task or finger oscillation task, essentially how quickly she can coordinate movements, a tapping movement of her fingers. And she performed in a severely impaired range for her left non-dominant hand, but in the average range, or where we would expect unimpaired range for her dominant right hand. And as I previously mentioned, there were no difficulties with her mood. So even though she endorsed, at least one item on the GDS, the score that we're looking for, and this is the short form, is a 5 or above. That's where we start becoming a bit more concerned about clinically significant mood issues. And that's important to note in the context of some of the difficulties she reported, including, crying more easily, laughing more easily, kind of uncontrollable emotions. So as many of you know, all of the scores as well as the data that we collect from our participants and co-participants are summarized and reviewed in consensus. And at the time, these were kind of the impressions. So certainly all cognitive scores were in the impaired range, though these were likely impacted, as Navid mentioned, by poor speech production and limitations in comprehension. It was very difficult, partially by nature of the battery and partially because it was already 2010 and her symptoms seemed to have really significantly progressed to this point. So really looking at differentiating strengths and weaknesses within the profile, that was really tough. And it's also just tough to understand how much of her deficit that we're seeing was related to the task itself and the content that we're trying to measure, as opposed to just difficulty understanding instructions or producing an answer, whether in a written or verbal format. However, it was noted that memory, language, and executive functioning are notably impaired with language testing. Even though it was limited and we're really looking at naming and fluency here, we still see pretty powerful evidence of language difficulties. At this time, given that we didn't have prior neuropsychological data, it was noted that it was likely consistent with a degenerative process, mostly based on subjective report. And the diagnosis given was dementia, probable AD. And although I certainly wasn't there in 2010, I'm assuming that this is, probably in part due to the prominent memory difficulties, as well as the executive and language problems that were seen. So she did complete another evaluation the following year. So she did come back. She was 54 years old. Interestingly, at this time, she reported that the predominant symptom and also the first symptom that she noted was language as opposed to memory. She sort of changed, or the co-participant changed the narrative that really was language that was the most notable first affected domain. As you can see, her CDR score increased to a 5, and this was primarily because certainly she had some deficits before, but they had increased in terms of the breadth of the deficits and also the severity. So now she's having more difficulties with memory, orientation, judgment, community affairs, homes and hobbies. Really the only thing that was preserved was personal care, so those more basic ADLs. She also noted moderate difficulties with language and mild difficulties with behavior, an increase in mood symptoms. While the neurological exam was largely normal, there was some notes about mild left-hand slowing and bilateral apraxia. And again, when we look at her functional abilities, so those basic and instrumental activities of daily living, we do see that she is having more difficulty, some with the same kinds of issues that she had before, financial management, shopping errands, etc. But she was also having kind of greater and more severe difficulties with kind of household chores, tracking and orientation. Of note, she was still driving at this time, and she was maintaining and managing her medications independently. So supposedly using a pill box, not needing reminders, and was doing that effectively, which I think is notable in the context of even the data we saw from the year before. So this is why I say our testing was limited. So she completed the MOCA and achieved a score of 3 on that test. So it seems like, again, just kind of reading between the lines without having significant behavioral observations, She just had such difficulty with performing the MOCA that it was determined that she was unlikely to be able to achieve kind of a valid neuropsych assessment or cognitive assessment. So no further testing was completed at that time. So certainly there was evidence of a decline in cognition based on some of the symptoms she was describing, particularly with speech production and comprehension, continued functional decline. And so certainly this would be consistent with a degenerative process even year over year. And the diagnosis remained dementia with probable AD being the etiology. So I'm not going to spend much time on this because we are going to have some discussion shortly. But, you know, I think one of the questions that we really are weighing here in both the clinical and the research evaluations is this Alzheimer's disease? Is this some form of PPA? Is it this logopenic variant PPA with more of an AD pathology? Certainly, given that she has predominant language symptoms early on, her age, the fact that her language deficits progressed pretty quickly, that her functional difficulties really do seem to be attributed, at least in large part, to language production and comprehension. Certainly, I think there's some concern about a PPA here. And although Navid will go into this a little bit later, I do just want to take a quick moment to talk about how neuropsych can be helpful in differentiating between PPA subtypes. And so, you know, one of the things that we can do is look at language on a very fine-grained sort of basis and look at not only just naming, but other aspects of language like comprehension, repetition, you know, your actual motor production of language. So, you know, certainly we know that there are 3 different subtypes of PPA that we would consider. The first two being subtypes of FTD, and the third really being considered more of a AD atypical variant. So in a semantic PPA, what we're really seeing here is a breakdown of the understanding of meaning and connections between words. So we see impaired single word comprehension, difficulty with object knowledge and naming, whereas we see that the actual pronunciation and production of the word is not necessarily impaired. So motor speech and grammar seem to be generally fine. Individuals tend to be fairly fluent. They just lose kind of the content. It becomes sparse, where they might have been able to specifically name something like a pigeon or a parrot or a specific type of bird. It would slowly become bird and then animal and then thing or something like that. So you really start to lose the connections and the semantic meaningfulness or context of the word. And we know that, you know, semantic PPA tends to be associated with difficulties in the kind of anterior parts of the temporal lobe. In contrast, a non-fluent PPA variant is sort of the opposite, so the inverse of that. So while we see that individuals seem to maintain the meanings and the semantic knowledge associated with words, the production of those words becomes impaired. So they have difficulties with articulation, grammar rules, those sorts of things, as well as kind of motor speech. So producing complex sentences becomes really difficult, very halting, unusual paraphasic errors, those sorts of things. Here we see more difficulties in the inferior parts of the temporal or the frontal lobe. And finally, we have this atypical variant, this logopenic PPA, which does tend to be more associated with common AD pathology. And it's, you know, it's interesting because in this case, what we're really losing, or what the patient would really be losing, is sort of knowledge or memory of the phoneme, the ability to access the phoneme, as well as some of the semantic connections. So here we see that while single word comprehension and sometimes object naming are spared, or sorry, object knowledge is spared, the ability to name it, to access that word and bring it out without circumlocution, that tends to be impaired. So they describe more word finding sort of difficulties. There are no difficulties with motor production, so the pronunciation of words. However, and grammar is generally maintained. However, their fluency becomes kind of impaired in the sense that there is all this circumlocution and halting and difficulty accessing the vocabulary words. So you hear that kind of tip of the tongue phenomenon. And interestingly, when we look at things like repetition in complex sentences, we do see a length-dependent effect. So the longer the sentence or the longer string of words, the more impaired the person will be in a logopenic PPA subtype. So I'm sure Navid will touch a little more on kind of AD versus PPA later on. So I'm going to turn it back over to him to talk about the next set of data.
I think, all right, so thanks, Annalise, for giving that part. I'm assuming that everybody can hear and my screen is being shared. So we talked about the neuropsychological data, and it would have been nice if we could sort of get some sort of a feedback from the group in terms of if anybody has thoughts as to going back to the initial clinical impression, whether we think this is primary progressive aphasia and whether we think this is more consistent with non-fluent or not. So feel free to chime in either through the text message or the just unmuting yourself, but I'll try to do some of this as we go along. So putting both sets of data together, we try to sort of take the neurological approach to the organizing our thoughts. So we can start with sort of the localization of what do we think, where do we think the problem is from. And we have to keep in mind that, as we know with neurodegenerative disorders and also many other brain disorders, we're not necessarily looking for just a single lesion. We're trying to just see what parts of the brain seem to be involved based on the clinical history and the neuropsychological data. So if we know that the language is involved, so we would assume that we're starting in the middle. Now we're probably going into the left hemisphere in a very realistically depicted image of the brain anatomy. So most likely we're looking at something that involves the left hemisphere. If we think about that, based on the sort of the localization that Annalise had on the previous slide, involvement of the fluency and grammar is often associated with more the frontal, the inferior frontal lobe. I'm going to try to sort of bring this up a little bit. Okay, so it will be somewhere where classically it used to be in the Broca's area, but probably in the surrounding networks as well. That would be where we would suspect some difficulty with fluency. If we were more concerned about single word comprehension, we would probably be looking more towards the temporal pole. But it does, at least it's unclear, but it doesn't seem like that was a major feature. There was some comprehension problem, but this comprehension wasn't just limited to the single word and the knowledge of the objects per se. However, there was some comprehension involved. And with that, it takes us a little bit back further, probably not this high, but more into the temporoparietal cortex. So at this point, we can sort of implicate some involvement of the left frontal and also left parietal regions. There was some difficulty with executive function, so that again sort of re-emphasizes that there are some frontal dysfunction or involvement. The question of visuospatial, it was somewhat provided by the history, some on the clinical, but it wasn't really a strong feature in the neuropsychological. But this could also implicate some involvement of the right hemisphere. Also, if we take into account that eventually there was some, involvement of the finger tapping was slower on the left side, so perhaps there was some involvement there. So we put a little vector pointing to the right hemisphere. But visuospatial tasks also often involve involvement of the even dominant parietal lobe for the integration of the information. So this could still push that vector a little bit further back. Involvement of memory also, as well as some of the other features we talked about, could implicate the temporal lobe also, although this was a relatively later findings. So basically, then the take-home message is not to have a single lesion here that sort of we hang our hat on, but more that there is multiple foci that are involved in terms of where we think the pathology is, rather than a more focal localized lesion. So then we can look at the data and see what was found. This is a perfusion, well, this is not a perfusion, it's actually a PIB scan, a PET scan with Pittsburgh compound, but which normally it would be, marking the, we look for the amyloid marker. However, if we look at the scans early on, before there is basically any time for the binding, for the specific binding, we can sort of get an idea of what the perfusion, distribution of the blood flow in the brain is. So it somewhat correlates with what we would see in an FTG scan. Although there are some differences because it's a little bit more perfusion dependent rather than brain activity, but it gives us an overall idea of what the active areas of the brain are. So in this picture, sort of starting from the sort of the more superior cuts here, and then moving down as we go up to the first scan. So some of the patterns that come across is that, as we sort of saw in the previous hypothesis of where the lesion is, red being the more active areas of the brain or higher perfusion, and the green being the lower, and the blue being almost none in the white matter areas. We see that there is an asymmetry when we compare one side as compared to the other, which sort of runs for the most parts of the brain. And you can notice it in the more superior cuts, and it continues with the left parietal having less perfusion, and it continues notably here particularly, and involves even the parietal temporal regions, which you can still see there is some right-sided involvement, but still the left side is more prominent as we go through. In addition to this, the posterior hypoperfusion that we see, there is also some frontal involvement that is noted, especially in the more inferior frontal regions. Okay. So interestingly, the perfusion scans somewhat fit with what our hypothesis was. Now, in terms of etiology, the differential diagnosis, this is not, by the way, a real differential diagnosis. I mean, we wouldn't think about all of these etiologies if a patient like, this comes to the clinic, but this is sort of a broad idea of what are the things that we should think about if we are thinking about the process that is relatively rapid, at least earlier on in the disease, although as time goes by, it appears to be more of a pace of a neurodegenerative process. So when running through this list, it's helpful because we know that we're not probably looking at one of the more localized primary progressive aphasia. We're really, are drawn more towards a process that is more globally involved. So in terms of the neurodegenerative diseases, the early onset Alzheimer's disease becomes the sort of the front runner in terms of the diagnoses. Obviously there can be other neurodegenerative processes that can give a similar picture, but sort of having this information helps direct us towards more of a global process. The asymmetry of the findings makes some of the other etiologies like metabolic and so on less likely. The inflammatory, in particular autoimmune encephalopathy, is always something that we consider because it can have more asymmetric findings, although the pace of the disease really is not consistent with this. So based on that, this will be our sort of number one on the differential, and then we would like to get some more information with regards what the pathology might be. So with that, we can continue with the PIP scan and looking at the actual amyloid. So this will be later on after the injection of the tracer. We would wait for more specific binding. This is just a picture to show what the control, what the normal person would look like. There will be some non-specific binding of the white matter, but that will be at a relatively low level, but there will not be much of a cortical involvement. In cases of Alzheimer's disease, there is often a higher binding in the cortical areas, and that can also be contrasted with the cerebellum, which usually does not have much of a binding. And in case this is the scan from our patient, which you will notice there is a high level of binding in the cortex as seen in this, as well as if we compare it to the cerebellum, the level of binding in the cortex is much higher, which is more similar to this kind of a picture. So this is a profoundly positive amyloid scan. So with that, I was going to now transition to the neuropathology. I don't know if any questions or anything before we do that.
I can take over and talk about the neuropathology at this point. Everybody can see my PowerPoint. So those of you who don't know me, I'm Kyle Conway. I'm the second-year neuropathology fellow for one more day. So this is my swan song. I really enjoyed participating in these conferences. So I'll go through the pathology, the autopsy pathology, I think from the perspective of the differential we just discussed, and how the approaches we use to resolve that. So all of our evaluation begins with a gross or microscopic examination of the brain. And for our ADRC brains, we receive a fixed hemibrain that we will use for pathologic analysis, and the other half of the brain is frozen for future studies. So just a couple quick notes of the gross pathology. The brain weight was 1,100 grams, which we generally consider the normal to be between 1,200 and 1,400. So this is smaller than normal, which is indicative of an atrophic brain. Just to kind of briefly touch on the the broad differential. A few things you can even see here. I think you can sort of appreciate that there's some atrophy that's relatively global. It's most pronounced in the frontal lobe, but also in the parietal, and the temporal is not really clear in this section, but there's some widening of the sulci here. That's really the best indicator from this point of view of atrophy. With regard to some of the other things that were on the differential, for example, MSA, the cerebellum is full. The cerebellum is not atrophic. From a sort of top-down view, you can really, I think, better appreciate what I was just discussing in terms of the width. These gyri should be essentially back to back, and there's a lot of space in between them. You can see, and again, it's global. So from a sagittal view of the brain, you see all of the same things I just described. The pons is full, the cerebellum is full, and there's this cortical atrophy. So we section the brain in coronal sections. I've just picked out a few that I think are kind of helpful for again resolving the differential that we just discussed and how we approach the pathology here. So again, you can appreciate the atrophy of these gyri. This is the posterior hippocampus. A good indicator of atrophy within the hippocampus is the width of the dimension of the lateral ventricle nearby. So this should essentially be tight up against the temporal lobe here. So the space is kind of indicative that there's at least a mild to moderate or more degree of atrophy here. A few pertinent negatives. The substantia nigra is relatively well pigmented. That would be if Lewy body disease were a consideration. There is a little bit of depigmentation here, and I'll show you that microscopically, but that's not always specific for Lewy body disease. There can be other involvement of other pathologies in the substantia nigra. So that's the main microscopic. And before I move on, I just, we discussed, I think, a lot about the localization of this lesion and how it's, or how maybe it won't be explained by a localized lesion. And we don't, at the point of autopsy, we don't really look into the sort of granularity of specific regions of the brain beyond just sampling from each lobe. So just for your own reference, we usually sample the frontal lobe in this sort of like watershed area up at about the level of the anterior cingulate gyrus, and then when I show you sections of the temporal lobe, that'll be this sort of middle and superior temporal lobe here. So moving on to the microscopic findings, I'll first just talk about the general findings on the H&E stain slides, and then I'll move on to the more specific immunohistochemical findings. So in the section that I just indicated to you of the frontal cortex, it's actually, for the degree of atrophy that was seen macroscopically, it's not the most severe. There's a little bit of this bumpiness to the surface of the cortex is indicative of atrophy, as well as a little bit of this superficial, what we call it spongiosis or microvaculation. You can sort of see a little better here that there's just this sort of this texture that it's loose and sort of falling apart. That's indicative of dropout of the neuropil due to dropout of neurons, which is what accounts for the atrophy. So moving, actually probably on the H&E stain sections, probably the most interesting part is the hippocampus. First, it's hard to get a nice picture of the entire hippocampus, but this is just a little indicator of, you can see the granular cell layer here, or the dentate layer here, and then Ammon's horn or the CA layers wrap around in this fashion. And kind of a nice pertinent negative is that this is all intact. There's no dropout that you would see in something like hippocampal sclerosis. As we go to high power in the hippocampus, there's a few interesting things. One is, this is a nice example of granulovacuolar degeneration. It's a non-specific change that can happen with age, but is also very commonly seen in the context of Alzheimer's disease. But again, it's not specific. In the CA4 layer, there's you don't always see it that clearly on these H&E stain sections, but we have these little patches that you can see in the neuropil, and these are plaques. These are probably a neuritic plaque and a diffuse plaque, and I'll show you that I will prove to you soon that these are made up of beta amyloid. And then one other finding, again, can be variably difficult to find on H&E, but this sort of fibrillary structure within a neuron here is a neurofibrillary tangle. So I will, as with the plaque, I will prove to you that those are made of tau. So those two findings already, like at this point, we're sort of clued into the idea that we have Alzheimer's disease pathology. On the H&Es, we don't have evidence at this point of other considerations in the differential diagnosis. For example, we don't have balloon cells that you might see in FTLD. It's really everything at this point points to Alzheimer's. In the substantia nigra, you can see the neurons there are pigmented. So you can see that we have a pretty good population of pigmented neurons with just some regions of maybe a little bit of dropout. I don't have a high power image, but there's no evidence of Lewy bodies, which are usually readily identifiable on these sections. So I will proceed with how we, using immunohistochemistry, evaluate for Alzheimer's disease neuropathologic changes. So this process we do according to the 2012 NIA guidelines. And essentially, the point of this chart, which I will walk through in detail, is we evaluate both the amyloid pathology, and what that means is we evaluate, so there's part A of this is the distribution of amyloid plaques. Part C is the frequency or density of amyloid plaques. And then part B is the distribution of tau pathology. So we put these three things together, and I will go through this. And what the end result is we come up with the low, intermediate, and high indicates the probability that Alzheimer's disease neuropathologic changes account for the patient's clinical presentation during lifetime. So I'm going to start with, I'll start with this A, the amyloid plaque score, and we use the Thal phasing system. And this just looks very complicated, but it's sort of, if you put it in a big picture context, amyloid pathology in Alzheimer's disease starts in the neocortex, and it progresses down to the cerebellum, brainstem, even into the spinal cord, and everything in between. You know, there's sort of these gray areas as it progresses along that pathway. And this is in the paper that Thal published on this topic, basically the percentage that you would expect to see in the different phases of amyloid pathology. So what do we mean by amyloid pathology? So this is just a high-powered section of this patient's brain stained with beta amyloid in the frontal cortex. And you can see that there's essentially two different structures here. These are neuritic plaques. They have a central core and this kind of corona that radiates out. There are also these diffuse plaques out here. For the purposes of density scoring, we score the neuritic plaques. That's what is most important. So since I'm starting off with part A, I'm going to start off just running you through the distribution of plaques in this patient's brain. So these are all of our samples of the cortex. The brown are abnormal amyloid deposition. If you stained a healthy, unaffected person's brain, you would expect there would be no brown in these. So this is all abnormal. So there's amyloid deposition in the frontal cortex, temporal, parietal, and occipital. And I think you can appreciate even at this low power that a lot of these are those neuritic plaques that I was describing. So because that's neocortex, that gets us, we're in Thal phase 1. So moving on to Thal phase 2, here's just a section of the hippocampal formation. You can see the dentate up here. The fact that we have plaques up here in CA1 and down here in the entorhinal cortex, that's up to Thal phase 2. These are just kind of some representative sections. It's a little more, a little more detailed than this, but these are the important parts. Moving on to what would get us to Thal phase 3, we have involvement of the cingulate gyrus here. You can see there's this big white matter tract here is the corpus callosum, and the cingulate gyrus sits right above it. The nucleus basalis of Maynard in the basal forebrain is an important site for Alzheimer's pathology, and then the amygdala is also frequently involved. So we're up to a 3. As the amyloid moves into the midbrain, before it gets there, an important spot to look is the CA4 layer of Ammons horn in the hippocampus, and that is involved. Here's a section of the substantia nigra. You can see that we still have those pigmented neurons here, but in the background also plaques. And then here's a section of the midbrain. So this is the aqueduct, and this is the periaqueductal gray, or the central gray. And then kind of the last part as we get down deeper into the locus, here's again the aqueduct and the locus ceruleus. And then probably the most important part is the cerebellum. In both the molecular layer and the granular cell layer, we have plaques as well. They will often be less frequent at this point, but the presence of any amyloid pathology here means that we are a Thal phase 5. So just to kind of briefly run you through this, right? We start off with the neocortex, CA1, entorhinal, so on and so forth, up until essentially the presence of amyloid pathology in the cerebellar molecular layer is essentially diagnostic of putting us in that phase 5. And this amyloid pathology is specific to Alzheimer's disease. So the presence of this severity essentially rules out any concern for other tauopathies in this context. So that puts us in this realm right here. And then the next part is our CIRAD score, or our density scoring. This is sort of a semi-quantitative score. I won't belabor this point, but basically we have in a sort of medium to high power field, 1, 2, 3, 4, 5, 6, 7, 8. We have plenty of neuritic plaques here, and that's enough to get us up to the C3, which is frequent. So I think I may have put these out of order, but to move on to the final part of it is the Brock staging, or the tau stage. And so what we do here is, so essentially tau or Brock staging starts in the hippocampal formation. It starts around the transentorhinal region, and then it progresses up into the hippocampus proper. And as it moves out, it will move up into the insula, the cortex, and then ultimately into the neocortex and the primary visual and motor cortices. And Brock is the tau is staged from 1 to 6, and I think this patient had pretty severe tau pathology, so I will just kind of show you really briefly. I neglected to put in a high power image of a neurofibrillary tangle, but if you could look at these at high power, you would see that that's the pathology here, is tons of tangles and this very dense network of tau neurites in the background, or neuropil threads in the background. So if you have this image of our entire hippocampal formation, where it's dense tau pathology, the subiculum is often sort of less affected even in very late disease, all the way through the transentorhinal region and out to the temporal lobe. You can see that image essentially corresponds with, even a 5 or a 6. I guess the 6 doesn't show that part, but so we're, very severe on that hippocampal section. And then just to go on and show you all of our cortical sections, you can see are affected relatively equally. There's severe tau pathology in the frontal lobe, temporal lobe, parietal lobe, and occipital lobe. And the occipital is important for us because that's the only primary cortex we routinely sample. And so we have, you can see that the occipital lobe is affected, and then there's this white matter band, the line of Gennari, that runs here, and then beneath it is the primary visual cortex. So the involvement of the primary visual cortex puts us into a Brock 6, which corresponds to the B3 here. So we've already seen that we are A3 due to our phase 5 FAL pathology. We are C3 due to our frequent neuritic plaques, and we are B3 due to our Brock 6. So that puts us in this category that we have a high probability that that Alzheimer's disease neuropathologic changes account for the patient's lifetime symptoms. Just one other thing to briefly comment on that I don't think probably plays a major role in this case, but is always worth noting, is in some of these sections, all of the cortical sections stained with beta amyloid, there's this deposition in leptomeningeal and cortical vessels. So this patient also has a mild or a moderate degree of cerebral amyloid angiopathy as well. So, but in this context, Alzheimer's disease neuropathologic changes are the primary diagnosis. Anybody have any questions about the pathology? All right, in that case, I will stop sharing and I think pass it back to Navid to finish us up with discussion.
Oops. Let's go back here. Since we're at 1 o'clock already, I won't really do much in way of discussion, but just wanted to sort of bring things to a summary. So as you noticed from the clinical side, we sort of started on this side over here with a non-fluent aphasia, which then as more clinical information came about, as well as the imaging data, we were then more going towards a more diffuse disease of Alzheimer's type, and some of the features in the patient's language difficulties were more suggestive of a logopenic picture rather than a pure non-fluent issue. The main point of this is to show how complex this can be. First of all, from a clinical perspective, we are not language pathologists. It's often difficult to categorize the symptoms of the patient into one of these categories. And often we end up sort of guessing. And the reality is that the picture is not always that clean. There's often a lot of unclassifiable aphasias. And then in addition to that, the correlation between each sort of each set of symptoms and the underlying pathology perhaps is not as tangled as I've shown here, but it is not as straightforward as we think. So trying to sort of bring all of this together, I wasn't so much going to talk about, a big unifying picture, but there were just some features that were interesting that I thought I would bring up and share as sort of points of discussion. One was the idea, is the PPA a distinct entity or is the first step towards a global degeneration? And I think that's more of a philosophical question. If you're among the people who lump things together, you would think that PPA is just the beginning of something else, whereas if you thought that you're more of a splitter, more that PPA is an actual distinct entity. And I think most people would fall somewhere on the fence as to whether it's one or the other. But it is interesting to note that early onset Alzheimer's patients often have a different presentation, a distinct clinical presentation than the late onset Alzheimer patients. And we already know that early onset Alzheimer patients that are related to a single gene mutation have some peculiar features that go along with that genetic mutation. But even among early onset Alzheimer's patients who do not have a single gene or a known single gene mutation, only 60% of them have the typical features of Alzheimer's disease. And the remaining have more focal variants, which can include language deficit, visual spatial deficits, and initially fall into the category of a posterior cortical atrophy or a logopenic progressive aphasia. The other part that I just was interesting is this repetition as a hallmark of logopenic primary progressive aphasia. We often say that, the way to distinguish whether this is logopenic is whether they can repeat. And I just wanted to sort of bring up some of the work that has been done that shows actually repetition is not a simple entity. It depends on if we're talking about single word repetition, in which case, folks with even non-fluent can have difficulty with repeating a sequence of words. And this can be partially related to the difficulty with performance on a digit span, which is not related to words per se, but with pronouncing of the words, with getting at the phonemes, and so on. So single word repetition is not really the way to go. And even when it comes to sentence repetition, which is something that should be used for distinguishing logopenic aphasia from the other ones, the phrases that we use, such as, it's a beautiful and sunny day today, often is not sensitive enough. And we have to really look into longer sentences, which can bring out the primary progressive, the logopenic component of the aphasia. So, putting all of that complexity together, I just wanted to also put out the point that classification of primary progressive aphasia is a challenge and it is complex. And since we do have a cohort of patients that come in and eventually go through the brain bank, I know that right now our sort of protocol is to do the regular battery of neuropsychological testing, but it might be a good idea to start thinking about a better characterization of the subset that have prominent language features, even if they are not necessarily in the primary progressive aphasia category, but just have language features that are prominent. So with that, I will thank everybody for your attention. And if there are any questions, even though we've run over time, be happy to stick around.
Hey, Navid and everyone, it's been a really, really wonderful presentation and excellent discussion with multiple didactics. So thank you all. This is really great. Navid, just to follow up on your last point, I think that would be really a fantastic use of our cohort, because that is going to be one of the populations that we really target. So, you know, I think that if we can identify some of these measures, of course, the trick is finding a time to fit them in, right?
Right.
But I think that doing this, and I would also advocate that we have a visual spatial protocol as well, because things like PCA, you know, we can find some really interesting differences, and given the longitudinal nature, this could let us really examine some of the earliest symptom onset, and you know, leverage the whole spectrum of data we're collecting. So I would definitely say let's follow up on that. It's a great idea.
Okay, great. I see some questions on the chat.
Yeah, I can just jump in quickly. For the question about the tau staging, so we use AT8, which is a phosphorylated tau antibody. So it stains abnormal phosphorylated tau.
And I think that
questions?
going once, going twice. All right. So thank you all for listening. I'll just let Erin, I guess, sign us off here.
Thanks, Navid. Thanks, everybody, for being here. Quick reminder, the post-event eval is in the chat box. I'll also send an email to you all after this. Please fill it out. We appreciate all your feedback. And don't forget to claim CME credit if you need it. Thanks, everybody. Bye.